My name's Iqbal Syed and I come from Edinburgh and I practice otology and lateral skull-based surgery there, and I'm going to be speaking on the role of intratympanic therapy in Meniere's. I would just like to start off by defining the two conditions. Now, these are definitions from the Oxford Medical Dictionary, and you can see that a syndrome is defined as a collection of signs and symptoms known to occur together without a cause, whereas a disease is a morbid entity characterized by at least two of the following three criteria. And I'll let you read that. But if we stick to these definitions, what is AIDS? Is it a disease or a syndrome? I mean, we refer to AIDS as a syndrome, but if you look at the definition of disease, it fulfills at least two criteria. We know the recognized etiologic agent, and it does have identifiable group of signs and symptoms. For many years, if you look at the literature, it is pretty confusing, and a lot of authors say that the term disease should be used where the cause is not known, and syndrome should be used where there is a known cause. Now, in literature, there's no differentiation between disease or syndrome. And if you look at the best evidence for this, 4 out of the 5 Cochrane reviews in Meniere's basically use the term disease or syndrome, which is why I have elected to continue to use this term. So I'll let you read this quote. It is a riddle wrapped in a mystery inside an enigma, but perhaps there is a key. Now, this is a comment from Churchill on the Soviet Union, which was broadcast on the BBC in October 1939, and it can be aptly applied to Meniere's, because you will see from my next slide that we don't know too much about Meniere's than what we knew about a century ago. So I'm just going to briefly touch on the historical perspective. So 1861, the condition was described by Prosper Meniere, whose name still bears the condition. Charcot in 1874 was the first one who described the signs and symptoms of the condition in his publication Maladie de Meniere. Professor Pulitzer was the first one who actually described the pathology of the condition. And it was not until 1904 where Richard Lake did the first surgery for Meniere's. So this was done at the Royal Ear Hospital in London in the United Kingdom, and the patient essentially underwent a radical mastectomy and a labyrinthectomy. She was a young girl and she could not, she was in hospital for 3 months, could not walk for 10 days, but then was cured of vertigo. And over the next 50 years, there are various sort of well-known authors and otologists like Hall, Pike and Keynes and Jackson that gave various descriptions of the condition. It was not until 1972 when the Committee on Hearing and Equilibrium and the American Academy, they devised guidelines for the diagnosis and evaluation of treatment results, reporting of treatment results. Now, this guideline was updated in 85, further reviewed and further updated in 1995. And this is the 1995 guideline that most of us would follow and most of us are familiar with. I just want to point out that a lot of if you look at the definite criteria, a lot of these conditions do not appear simultaneously. So it can take up to 2 or 3 years for somebody to progress with just tinnitus to hearing loss, vertigo and oral fullness. So somebody who's got possible or probable Meniere's in a few years' time can then convert to definite Meniere's. So what are the treatment options? The treatment options are diet modification, low salt diet, medical treatment, beta-histine, Meniere device, surgery, etc. But I'm just going to concentrate on intratympanic therapy for the purposes of this presentation. So we can divide intratympanic therapy into steroids, aminoglycosides, antivirals, and others. So with this in mind, the types of studies that I looked at were just randomized controlled trials that looked at patients using the definite Meniere's criteria, using the American Academy definite criteria. And these patients had some form of intratympanic therapy comparing that to an alternate treatment or a placebo. A standard database, standard sort of Cochrane review style databases were searched. Search was restricted to English. There was no restriction of publication date, and the appropriate sort of keywords and appropriate medical subject headings were used in various combinations. And the primary outcome measure that I was interested in looking at was vertigo, so severity and frequency of vertigo as defined and suggested by the American Academy criteria. I also looked at secondary outcomes to see if there was any change in hearing, any change in tinnitus, any change in oral fullness, complications, any quality of life assessment studies. So this was basically a flow chart, and you can see from the top that I started with 800 citations, and applying various filters and inclusion and exclusion criteria ended up with 10 randomized studies, of which 7 were analyzed, and I'll come to that later on as to why the 3 studies were excluded. So there were 2 studies on steroids, 2 on intratympanic gentamicin, 1 comparing intratympanic steroids and intratympanic gentamicin, and 2 other studies. So I'll start with the 2 studies that I looked at for intratympanic steroids. So interest in the use of intratympanic steroids basically originates from the work by McCabe et al. In 1979, who described the use of steroids for autoimmune disease. But it was not until 1987 where Sakata published a study describing his results on Meniere's using intratympanic steroids. Pans et al. In 1999 published a very famous paper where he did animal experiments, and he basically showed that if you inject steroids intratympanically, the concentration of steroids in the inner ear fluids is a lot higher than when given orally or intravenously. It is postulated that after the injection of steroids through the tympanic membrane, they pass on to the middle ear perilymph via the round window and the oval window annular ligament and the lacunar mesh in the bony wall. What is the rationale for using steroids? Well, different authors have speculated different reasons, and I'll leave you to read some of the reasons on the slide here. And finally, the question of what steroid should actually be used, methylprednisolone or dexamethasone. And if you look at the earlier studies, they've all used methylprednisolone because the results from animal studies showed that prednisolone stays in the inner ear for longer than dexamethasone. But if you look at some of the newer research, the absorption of dexamethasone is far better in the inner ear than prednisolone. Hence, most of the recent studies are now using dexamethasone. So there were 4 trials that I found, excluded 2 of them. Now, Silverstein in 1998 described a study, but it was a crossover study, and there were no results available for the study before the crossover. There was another study from Paragache in India, and this was excluded because the dose of dexamethasone was 0.2 milligrams per ml, which is a very low dose, and this was given through a ventilation tube, and the authors themselves admit that the patency of the ventilation tube was not checked. So the 2 included studies were the study by Garduno Anaya in 2005 and Lambert in 2012. And because of the lack of heterogeneity in the 2 studies, a meta-analysis was not possible. So here are the 2 studies, and you can see that both of those studies are prospective, randomized, double-blind, placebo-controlled studies. In the study by Garduno Anaya, he had 22 subjects, 11 of which were given dexamethasone in a dose of 4 mg per ml intratympanically, and 11 of them were given an intratympanic placebo. 1 injection was used daily for 5 days, and outcomes were measured at 2 years. And they basically showed that in the group that had the dexamethasone, 9 out of 11 patients had vertigo control as per the American Academy criteria. So they were in group A, so they had good control of severity and frequency of vertigo, and 2 of them had partial control, and none of them in the placebo group had any change or any significant change in vertigo. The second study by Lambert in 2012 looked at 44 subjects and basically divided them into 3 subgroups of 14, 16 and 14. The first two subgroups were given dexamethasone in different doses, 3 milligrams per ml and 12 milligrams per ml, and the third one was a placebo. Now the injection was given in a compound called as OTO-104, which is basically dexamethasone in a buffered solution with a glycol polymer to make sure that absorption of dexamethasone is improved when using this glycol polymer. And outcomes were measured at 3 months, and vertigo severity improved in both the patients with dexamethasone, but the frequency of vertigo was significantly better in the subgroup that had the 12 milligram dose. So in conclusion from this intratympanic steroids of 66 patients, we can see that there's evidence to support the effectiveness of intratympanic steroids to control symptoms of vertigo. Excuse me. However, the dose and frequency of dexamethasone need further clarification. Now, if we move on to intratympanic gentamicin, there were 2 studies. And just to give you a brief background, it was Shuckneck in 1957 that first described the use of intratympanic streptomycin for patients with Meniere's. However, gentamicin was then replaced, or streptomycin was replaced by gentamicin because it is more vestibular toxic and less cochlear toxic. It is postulated that gentamicin goes through the perilymph and the endolymph of the round and oval windows to the hair cells and then causes a state of constant hypofunction of the labyrinth, and brain adapts to this stage, and patients the symptoms of vertigo are improved. However, there is a risk of hearing loss, and we don't know what the optimum dose should be. Again, in regards to intratympanic gentamicin, I looked at 3 trials, excluded Bremer because the trial was, although it looked like a good trial, randomized controlled, double blind, the trial was abandoned halfway because they didn't have enough patients. So the 2 studies that I looked at were Stockrose 2004 and Postima in 2008. So you can see again, both of these were prospective randomized double-blind studies. Stockrose study had 22 patients, 12 and 10, 12 patients who got gentamicin in a dose of 30 milligrams per ml, and 10 got the intratympanic placebo. Injections were given intratympanically every 6 weeks until control of vertigo was achieved. So in patients with the gentamicin group, they had an average of 1.5 injections, and in the placebo group had about 2.8 injections. Outcomes were assessed at 6 to 28 months, and on follow-up, there was significant control of vertigo in the patients that had the intratympanic gentamicin. The patients did not report any hearing loss. In the Postima study, you can see there were 28 patients, 16 in the gentamicin and 12 in the placebo group. Injections were given every 4 weeks through a ventilation tube, and outcomes were assessed at 12 months. And again, there was significant control of vertigo in the group that got the gentamicin, although they did report an average hearing loss of 8 decibel in the gentamicin group. So on the basis of these 2 studies that had 50 patients, there is good evidence to support the effectiveness of intratympanic gentamicin to control vertigo. However, there is a risk of hearing loss, and hence caution is advised, particularly in those patients that have got serviceable hearing. Again, we don't know what the optimum dose is, and hence the suggestion that a dose-response study is needed. Touching on the study briefly that compared steroids with gentamicin, this is just one study done by Kesani in 2012. Again, this was a prospective randomized double-blind study that looked at 60 patients. 32 were given gent, 28 were given dexamethasone for 3 days, and outcomes were assessed at 1 year and 2 years. At 1 year, you can see that there was significant vertigo control in both groups. However, at 2 years, there was significant vertigo control only in the gentamicin group. The results for outcomes of hearing was sort of very selectively reported by the authors. In the gentamicin group, they had 4 patients had a hearing loss. Hearing was unchanged in 28 patients. In the dexamethasone group, there was a mild hearing loss in 10 patients, no change in 13, and some improvement in 3. However, the speech discrimination score was reduced in the gentamicin group. So on the basis of one randomized study, there is evidence to support the effectiveness of both intratympanic steroids and gentamicin to control symptoms of vertigo in patients with Meniere's at 1 year, but at 2 years, gentamicin seemed more effective. However, the selective reporting on hearing loss makes conclusions very difficult. Lastly, touching on the intratympanic antivirals, there was just one study, and the rationale for using antivirals is that we know that there is, from research, that there is an association between markers for the HSV virus and Meniere's. There was also a big study done by the Hauser Institute where hundreds of temporal bone from autopsy specimens were looked at, and it was found that in patients with Meniere's, the incidence of HSV DNA in the temporal bones was very high, a significant p-value. Hence, it is thought that one of the theories that could cause or be associated with Meniere's are viruses. I just looked at one study by Guyot in 2008 that had 29 patients. 14 were given ganciclovir and 15 patients were given a placebo. Follow-up at 1, 2, and 3 months. However, there was no difference in vertigo between the two groups. And last but not least, just touching on intratympanic latanoprost. Now, latanoprost is a prostaglandin F2 analog agonist, and it is produced in the inner ears, and there is good amount of research to show that there are receptors for this present in the inner ear. Rask Anderson in 2005 looked at a study of just 10 patients, which is a crossover study, where 5 were given latanoprost and 5 were given placebo, and he concluded that there was a significant reduction in vertigo at 2 and 4 months. However, the limitations here were the trial design and lack of adherence to the American Academy criteria. So what is the future for intratympanic therapies? Now, if you look at the clinical trials register, there are various studies going around the world in the United Kingdom, United States, and Sweden, other countries that are actually looking at multi-center trials for looking at intratympanic gentamicin, intratympanic steroids, and hopefully we will have more evidence for this in the coming years. And last but not least, this is again nothing to do with my topic, but when I was researching this, I found on the clinical trials website a very interesting multi-center study that was looking at using Viagra for endolymphatic eye drops, and this is actually a multi-center study that is being done in Australia. It's not completed yet, but it'll be interesting to see what it shows. So in summary, on the basis of 2 studies, we can say that there's evidence to support the effectiveness of intratympanic steroids to control vertigo in Meniere's. On the basis of 2 studies, there's also evidence to support intratympanic gentamicin. However, there is a risk of hearing loss in patients with serviceable hearing. On the basis of one randomized study, there is no evidence to show that intratympanic antivirals have any benefit in controlling vertigo. And there's no evidence to support any other intratympanic therapies. Thank you.
Thank you very much, Dr. Mohammed Iqbal Syed. We now entertain comments or questions for him. When you start talking about vertigo, your head just goes spins round. When man now takes us to randomized studies, but it was really well researched. I'm sure it must have taken you lots of sleepless nights.
It has, yeah.
Yeah, well done.
Thank you.
Any comments? It will really be pretty interesting when we see the outcome on Viagra.
Yeah, I just saw it in the clinical trials website, and I thought, it's obviously sponsored by Glaxo, who produced the drug. So, but they're obviously looking to other indications for using Viagra.
Thank you very much.